Welcome, everybody. The session is ready to begin. Joe Porter from the Institute for Healthcare Policy at the University of New Hampshire and co-chair of the APCD Council will moderate this session. Joe?
Hello, everybody. Thank you so much for joining us. We wish we were with you in Boston in person, but we're in our next best thing. We've got a great session around improving data quality with some really interesting use cases. We all who have been in data for any period of time know how important the quality checking of our data is. And so we're going to talk a little bit with some terrific speakers about some of their experience, and hopefully it will resonate with folks on the phone, and we can have a great, robust discussion about how their experience resonates with you, and hopefully we'll learn a lot from each other in the session. So I'm going to introduce each speaker as we go along, but I'm also going to let you all know that, but we'll be talking about hospital data, we'll be talking about environmental health data, we'll be talking about dental claims data, so we've got a little bit of everything for everyone. And also just wanted to say thank you very much to our session sponsor, which is the California Healthcare Foundation. So with that, it is my great pleasure to introduce, excuse me, Catherine Wachuku, who is the Associate Manager of Research at the Massachusetts Center for Health Information and Analysis, also known as CHIA. She has a wide range of responsibilities around the analytic products, including work on the Massachusetts Employer Survey and on hospital readmissions, which is where she's going to focus on talking with us about today. So with that, Catherine, I will turn it over to you.
Thank you, Joe. Let me just pull up my slides and
perfect.
Thank you for the introduction. Good afternoon, everyone. My name I'll be reporting on the quality, affordability, access, and outcomes of the Massachusetts healthcare system. And our data and reporting is used by a variety of stakeholders, including other state agencies, policymakers, researchers, payers and providers, employers, and Mass residents. Today, I will be presenting on the impact of an enhanced patient identifier on routine healthcare analytics using administrative data. I'll walk you through some of the background on this project, our objectives and study design, principal findings, and the significance of this work. I'll have a few minutes at the end of my presentation for questions. Over the years, the completeness and validity of patient identifiers, such as Social Security number, has been deteriorating in our administrative data sets. This poses a unique challenge to research and analysis that relies on SSN to link patient records across time and place. In Massachusetts hospital inpatient data, the proportion of adult discharge records with missing or invalid SSN nearly doubled between 2011 and 2018, with 9.5% of records missing SSN in 2018, up from 4.5% in 2011. This varies greatly by hospital, with up to 68% of discharge records missing SSN at certain hospitals, and it varies by patient characteristics like expected payer type and patient age. In this study, we examined the use of an enhanced patient identifier, or EPI, instead of SSN to link patient records and its impact on populations studied in a statewide readmissions analysis. The EPI was created using IBM Initiate Master Data Service, which utilizes probabilistic matching on all available and valid patient characteristic information to identify discharge records belonging to the same patient. The matching fields used were first and last name, date of birth, Social Security number, patient sex, zip code, address, and health plan ID. In order for patient records to match, one of the following criteria had to be met. These criteria cover many different scenarios, but in general, records were considered a match and therefore assigned the same EPI if 1, the records had the same organization ID and medical record number, if 2, all the matching fields agreed, and if 3, if SSN, date of birth, and health plan ID agreed and all other fields were missing. Additionally, if all fields agreed except one either disagreed or was missing, rule number 4, the records were considered a match. Or for rule number 5, if all fields agreed, but any 2 fields not including SSN and date of birth disagreed, that was also a match. Lastly, if SSN and date of birth were missing, but all other fields agreed, the algorithm determined the records to be a match. If records did not meet any of these criteria, then the records were not a match and were given different patient identifiers. The Massachusetts Acute Hospital Case Mix databases, which includes inpatient, emergency department, and observation data, were used for the matching. And data spanned from 2006 to 2018. 12 years of data were used to increase the reliability and validity of the matching, which included just over 20 million discharge records. For our analysis, we used the EPI to identify and link patient records in a statewide all-payer unplanned readmissions analysis, and results were compared to the same analysis using SSN. Analyses included adult patients discharged from Massachusetts acute care hospitals from state fiscal year 2011 to 2018. And CHIA adapted this readmission methodology from the Yale CMS unplanned hospital-wide readmission measure to accommodate an all-payer population, which we have been reporting on since 2012. And on to the principal findings. This figure here shows the trend in statewide all-payer discharges and readmissions using EPI versus SSN, with EPI discharges shown in the dark blue and EPI readmissions shown in the dark orange. From SFY 2011 to 2018, the EPI increased the overall number of eligible discharges in our readmissions analysis by about 6% on average, and readmissions by about 3% on average. However, I'd like to draw your attention to 2 additional findings. You can see that in the latter part of our study period, the EPI increased the number of eligible discharges and readmissions even more so than in the earlier years. This is because the proportion of records with missing or invalid SSN that get excluded in the SSN-based readmissions analysis has been increasing over time. In SFY 2018, the EPI increased eligible discharges by 8%, or about 42,000 discharges, and readmissions by 5%, about 4,000 readmissions. Secondly, you'll see that the rate of increase in eligible discharges is higher than the rate of increase in eligible readmissions, which remains true over the 8-year study period. I'll discuss this a little bit more when I share the EPI's impact on readmission rates, but we could hypothesize then that populations newly captured in the EPI analysis are less likely to be readmitted. When examining the effect of the EPI on hospital-level eligible discharges in SFY 2018, we saw a median increase of 4%, with one hospital's eligible discharges increasing by over 200%. This hospital had nearly 70% of records with missing or invalid SSN in 2018. Specialty hospitals were among those with the highest proportion of records with missing or invalid SSN. And so these hospitals also had some of the highest percent increases in discharges when we used the EPI. Similarly, for readmissions, the majority of hospitals saw an increase in eligible readmissions when using the EPI, with a median increase of 3%. The same hospital, with nearly 70% of records without SSN, saw an 120% increase in eligible readmissions in our analysis. The EPI also had a significant impact on the number of discharges captured by payer type and patient age. This figure shows the number of eligible discharges and readmissions by payer type between the 2 methods, with the dark purple line displaying the percent of records with missing or invalid SSN over time. Both the Medicaid and commercial populations had a high number of records with missing or invalid SSN in 2018, and they also saw a greater increase in eligible discharges and readmissions. The percent of eligible Medicaid discharges in our analysis increased by over 10%, or 7,500 discharges in this population, and commercial discharges increased by over 15%, which was just under 17,000 discharges in the commercial population. Patients with Medicare, on the other hand, had relatively low missing or invalid SSN over time, with only 4.3% of records missing SSN in 2018. And so they saw a much smaller increase in eligible discharges and readmissions in our analysis. So our SSN-based analysis has historically done a good job of capturing the Medicare population, whereas the EPI has enabled us to capture even more records for Medicaid and commercial populations, perhaps providing a more balanced picture of readmissions by payer type. On this slide, you'll see a similar figure with the increase in eligible discharges and readmissions by patient age, as well as the proportion of records with missing or invalid SSN in the dark purple. Adults aged 18 to 24 had the highest percentage of records with missing or invalid SSN, with almost 30% missing SSN in 2018. The proportion of records missing SSN decreases with age, with only 4% of adults aged 85 and older missing SSN in 2018. Similar to our findings by payer type, groups with the highest proportion of records missing SSN also saw the largest increases in eligible discharges and readmissions when we are using the EPI. Eligible discharges increased by almost 40%, or 2,900 discharges for young adults aged 18 to 24. Again, we can see that our SSN-based analysis already did a pretty good job of capturing information about older adults 65 and over, likely covered by Medicare, perhaps due to increased interactions with the healthcare system and therefore more opportunity to collect key identifying information like SSN. However, the EPI allowed us to capture records for the younger populations who may be more transient, less likely to utilize healthcare services, and perhaps less willing to provide that identifying information. Lastly, I wanted to show the impact of the EPI on the actual rates of readmissions over time. You'll see that the EPI in the dark red decreased statewide readmission rates by about 0.5 percentage point over the 8-year study period, though notably the overall trend of readmissions remained consistent between methods. As I mentioned in an earlier slide, this is generally due to the fact that when using the EPI, the rate of increase in eligible discharges is higher than that of readmissions. We can then hypothesize that the populations newly added to our readmissions analysis, such as patients with commercial payers or younger adults, have lower readmission risk, and that when we include them in our analyses, overall readmission rates decrease. Similarly, we could hypothesize that a readmissions analysis that relies solely on SSN to link patient records is more likely to capture those with a higher readmission risk, such as the Medicare population and older adults, which may not be representative of the inpatient population as a whole and could overstate the overall risk of readmissions in Massachusetts. However, I do want to note again that whether we're using the EPI or SSN, the trend in readmissions has remained consistent over the 8-year study period, which provides some confidence in our methodology and results. In conclusion, the EPI enabled us to keep otherwise valid and complete discharge records in our readmissions analysis and greatly strengthened our capacity to capture and analyze these records, especially for hospitals and patient populations with a greater proportion of records with missing or invalid SSN that we previously excluded. As the healthcare system continues to move towards more coordinated and integrated care for patients, it's critically important to note the methods by which unique patients are identified. Future studies should continue to explore how different linkage methodologies may impact the populations captured in and outcomes of key healthcare analyses. And now I'll open it up for questions. Thank you very much.
Catherine, thank you so much for that. That's terrific. So folks in our session, there are 139 of us in the session. I'm sure somebody has a question after that presentation. I'm going to pop my screen over to the Q&A so I can watch for that. We'll take as many questions as we can in the next minute or so, and then we'll move on to the next presenter. While we're doing that, I do want to ask, take a little moderator discretion here and ask the stark difference between commercial Medicaid and Medicare in the percentage of missing SSNs. Have you talked with the data submitters about if they expect that trend to continue in the various payer sets? Is that a function of the commercial plans not using their SSN in the development of member IDs, which is something that we've heard? Have you any sense of why there's such a big difference between the payer types?
Yeah, that is a great question. So in our analysis, we're using expected payer type off of the inpatient discharge records. And so it would be something that would be quite interesting to reach back out to the hospitals and see if there's a difference in willingness to report SSN depending on payer, or if it's driven by age, thinking about folks who have Medicare, their Medicare number closely aligns with their social security number. And so maybe that's easier information to get, but it is a great question that we could think about reaching back out to hospitals to see why there is that difference by payer type.
Yeah, that's really interesting. One other quick question that came in through the chat, and then we'll move on to our next presenter, which is, you used resampling, for example, bootstrapping when it comes to assessing the benefits of this approach and how you've done the linking.
That's great. That's a great question to ask. So we do use bootstrapping when we are developing confidence intervals for our hospital level readmission rates. And so that is something that we have used before to kind of see how these results remain reliable. But it is a good idea to think about using bootstrapping as we continue to enhance the algorithm, the matching algorithm, the next time around that we might run this EPI. It's a great question.
Great. Thank you. Okay, there are a couple other questions in the Q&A, which I will promise we'll get to if we have time at the end. I just want to make sure that we get through all of our speakers. So Catherine, again, thank you so much for that. If you could stop your file share, and we are going to move on to our next presenter, who is Mackenzie Malone. Mackenzie is a data manager for the Centers for Disease Control and Prevention's Environmental Public Health Tracking Program. She's been there since 2015. And she has the big responsibility for leading data submissions, updates, and validation, no small task, for the 500 tracking data measures. And she's going to talk to us about some of the experiences learned in doing validation of that breadth and depth. So Mackenzie, I will hand it over to you. And again, if you have questions that come to you as Mackenzie's talking, please feel free to put them into the Q&A as she's going along, and we will queue up as many as we can right at the end of her session, and any that we don't get to, we'll try to get to at the end of the session in its entirety. So Mackenzie, thank you so much for joining us, and I will hand it over to you.
Okay, thank you, Joe. So good afternoon, everyone. My name is Mackenzie Malone, and as Joe mentioned, I am the data manager for the Environmental Public Health Tracking Program at CDC, and we are housed within the National Center for Environmental Health. I want to thank you all for the opportunity to share some of the tracking program methodology. And today I'm going to be talking about the data validation of health data for use in environmental health surveillance. And I'll be sharing some of the tracking program's piloted solutions and lessons learned for handling this data. So here is a brief overview of what I'll be going over during my time today. I would first like to give some background on the tracking program and the collection of our hospitalizations and ED data through our annual data calls. I'll give a brief description of our validation process and introduce what we're calling the meaningful difference problem. And I'll then walk through some of our piloted solutions and lessons learned. So in 2001, the Pew Environmental Health Commission issued a report calling for the establishment of an environmental public health tracking network. Thus, in 2002, the Environmental Public Health Tracking Program was established. And the tracking program was established with the purpose to deliver environmental health data and inform decision-making. The Environmental Public Health Tracking Program funds 26 recipients, and that includes 25 states and New York City. This map shows our currently funded recipient states, shown in the dark blue, and the light blue indicates former tracking recipient states. So the CDC tracking program created and maintains the tracking network, which is a surveillance platform, and it brings together health and environmental data in one place. And as Joe mentioned, we have over 500 unique data measures. And our platform offers the ability to observe trends at the national and local level. The data hosted on the National Tracking Network are collected from various sources, including national partners, CDC programs, and of course, our tracking recipients. So the tracking program receives nationally consistent data from our tracking recipients through our annual data calls that occur in the fall and in the spring. The data structure for these files are defined through the development and maintenance of standardized data dictionaries and detailed step-by-step how-to guides. The data are submitted using a standardized XML schema format through Tracking Secure Data Submission Gateway. The data then undergo a thorough validation process before they are calculated as measures for display on the National Public Portal. So in the fall of every year, Tracking receives hospitalizations and emergency department visit data. There are 9 different data sets total for the different health outcomes. The health outcomes by data source are listed on this slide. The hospitalizations and ED visit data are abstracted according to ICD-10-CM definitions for each of the health outcomes. The ICD-10 code definitions are collaborated on between CDC and the recipients in our collaborative content work groups. Tracking does not receive record level data, so instead the data are submitted as single year data files by data source and health outcome, and are aggregated by the county level, stratified by visit or admission month, and some demographic variables. So the data are stored in the tracking environment in what we call tiers, and the tiers are defined by the data structure and where they are in the validation process. So this graphic is just a high-level overview of the data flow of our recipient data from submission through a data call all the way to publication on the National Public Portal. Upon submission, the data undergo a schema and quality check at the gateway before they are then received in the CDC environment in what we call the Tier 2 data. So for this presentation, I'm going to mainly focus on the Tier 2 data validation process. So once the hospitalization and ED data are through the gateway and have passed the general schema checks, the CDC Data Management Unit, along with the help from our contractors, perform a series of more in-depth data quality checks. These checks fall under 4 overarching themes. So they include strange patterns, lack or excess of data, outliers or inconsistencies, and unexpected results. Sorry, one second. So with unexpected results, we're referring to how well the newly submitted data align with previous years of data for that given state. So when the data are determined to be too different from the previous submitted data, clarification is requested from the submitting state, or a possible resubmission of the data may be needed. The previous solutions for these checks have been to calculate the count and percent difference of events between the new data file and the average across the 3 most recent years of previously submitted data. So this check uses arbitrary thresholds that were just decided on amongst the validation reviewers, and it resulting in this check being the most failed check and often requiring additional manual review of the output. Clarification of this check was needed for well over 50% of all the submitted files from year to year, and more often than not, the differences we were seeing were due to chance and not true data errors requiring resubmissions. So this kind of led us to what we're calling our meaningful difference issue. Is there a way to determine when the observed difference is meaningful? And how do we determine when change in data is due to chance or is a possible data error? So as we all know, surveillance data is expected to vary year to year. And that is, after all, that's the point that we collect this data. We want to observe trends. So how do we explain what is just expected variation in the hospitalization and ED data and what is error? And why is this important? The obvious answer is to improve our data quality, but we also want to have confidence in the observed trends that we're seeing in the data and the data we publish on our National Public Portal. Ultimately, we want to conserve tracking's time and resources as well, while maintaining the validity and integrity of our hospitalization and ED data. So over the past 5 years, the tracking program has piloted some proposed solutions to this issue. And I will walk you through each of these piloted solutions and how we found they performed on our inpatient and ED data. So our first piloted solution was a box plot check that was piloted in the spring of 2015 to visually observe our annual trends. So here's an example output of the box plot check. And this check is evaluated by the reviewers to determine if newly submitted data follows the existing trend. So some pros of this check is that it allows for the comparison across all the years of data submitted by that state and for that health outcome. And it shows the trend of data and allows the reviewer to spot possibly troublesome year files. Some cons of this check is that it is still reviewed manually, and the pass or fail of the check is based on the interpretation of the reviewer. So we found that this check was also not as useful for all of our tracking hospitalizations and ED data sets, particularly carbon monoxide poisoning or heat stress illness, which just generally show more variability from year to year. However, this check has continued to be used through all of our data calls and has been found useful for some of tracking's exposure data sets as well. In fall of 2016, we piloted tolerance interval checks. So for this check, we used the 3 most recent years of previously submitted data to calculate a 2-sided tolerance interval for each county within the state. We then compared the new county data against the intervals, flagging the counties where cases fell outside of the set interval. This check allowed for us to set the confidence and percent of population, so alpha and gamma, as our thresholds. We adjusted these thresholds while piloting to try to find an appropriate level for all of our data sets. So some pros of this approach was that it did involve a statistical test and it was less up to just a reviewer's interpretation. Some cons were that it still relied on our validation team assigning thresholds at the gamma and alpha levels, which we found that one value for each of these was not an appropriate solution for all of our data sets. When setting these different thresholds, there was concern also that we were casting too wide of a net or possibly too narrow, and we were worried about possibly missing errors in the data. Additionally, there are always assumptions to be made about data when using statistical tests, so that definitely warranted some concern. Most reports produced a large output for this check, so ultimately we found that this check failed more often than our other previous solution and wasn't solving our problem as we expected. In fall of 2017, we piloted a check to compare our crude rates. So this check compared county rates for the newly submitted data side by side with the average archive rate for that county over the 3 most recent years. It then uses a proc GenMod procedure in SAS using the 3 most recent years of archive as the comparison group to compare rates. This is the sample output of a proc GenMod procedure. I've highlighted here for you guys the rate and the p-value if you are unfamiliar with this kind of output. So some pros of this check was that we were able to use rates, and incorporating the population denominator helped to standardize our data, so we were not relying solely on the count data. And it additionally involved a statistical test. Some cons of this check were that we were comparing the data aggregated as county level data points. So there were some concerns on how well it was working for states with very few counties. Additionally, this check has been less successful for our very sparse data sets, like CO poisoning. This check, in combination with our box plot check and our other validation checks, have been proven useful. Lastly, in the fall of 2018, we implemented a check that utilizes standard deviations. So this check uses all previously submitted years of data for a single state and health outcome and calculates the mean and measures of spread for both the state and county levels of data. It then compared summary statistics from previously submitted data to the new years of submitted data. And this output only flags the counties where the new data is farthest from the archive mean for that particular county. So some pros of this check was that the calculated threshold was dynamic and was dependent on just the data and state of interest that we were looking at. It incorporated all years of submitted data rather than just focusing on the 3 most recent years alone. And it calculates this check at both the state and county level, making it rather easy to spot possibly just some troublesome counties. Some cons is that it did seem to be inconsistent with catching errors, and it was less successful, again, for data with small counts, such as our CO poisoning data or heat stress illness. So how have these efforts improved our data call performance? So since we began these efforts, we have observed a significant improvement in our fall data call for the collection of hospitalization and ED data sets. As you can see, the number of unique HOSP and ED data files has remained the same from year to year. However, in fall of 2015, 71% of hospitalizations and ED data recipient submissions needed follow-up, compared to only 36% in fall of 2019. We have also seen a noticeable reduction in the time it takes from the start of a data call to the data being published on the National Public Portal, shaving off roughly 2 months of processing time. I also wanted to note some additional successes of these efforts, that we have not only improved the newly submitted data validation process, but have also been able to improve the quality of data submitted prior to 2015. In the fall of 2019, in our data call, we observed an odd trend in some previously submitted data while reviewing our box plot checks. CDC worked together with the submitting state to identify where the issues were coming from and have the previous years of data resubmitted. The new data resulted in a more consistent trend, as you can see on the right. So some lessons learned. The hospitalizations and ED data visits data for surveillance purposes poses unique challenges in spotting data errors, particularly when this data is already aggregated. Exploring and piloting these checks to compare new years of data with already valid data have had some mixed results, but of our piloted solutions, the box plots have shown to be the most effective in spotting errors across all of the years of submitted data. The introduction of these checks have proven to conserve program time and resources while still maintaining the accuracy and integrity of our hospitalizations and ED data. However, tracking's work is not done. We do plan to continue to review and improve the validation process and pilot new ideas and solutions to continue to improve the accuracy and timeliness of our hospitalizations and emergency department visits data. So that concludes my slides for today. Thank you all for the time and attention, and I will be happy to answer any questions if we have any time now or at the end of the session.
Yeah, I think we have time for a couple of questions, Mackenzie. Thank you so much for that. And a couple of questions have come in, so let's jump right into those. The first question that was done, I think, should be fairly simple, which is a question of asking if all of your checks are done using SAS.
So our validations are done on multiple levels. So our CDC contractors first run the reports using SQL, since our data are housed in a SQL database. Then our CDC data management unit is running the same in SAS or R, depending on the reviewer. And we are comparing the results to make sure that both reviewers are seeing the same things within the data.
Great. Another question, are the data validations automated, and how long do the manual follow-ups typically take?
Right. So the production of our validation reports are automated, especially the ones that are done by our contractors in SQL. There is some manual review to review that output, but the way most checks are written are that the inconsistencies or the things that are unexpected are printed. So there is some manual review there. After both sides have been able to review, both our contractors and the CDC data management unit, we do some email follow-up with the states. So the time that usually takes varies depending on what we find in the data. Previously, as I mentioned, we were following up on these archive checks for well over half of our states. So there was and then the states themselves have to go and look at the record level data to see if what we're seeing is a true error or just the observed trend. So again, the time just varies.
Yeah, and I think the last part of that question, and then we'll move on, is it been in your experience that those benefits of doing those checks and revalidations are worth outweigh the costs of that process?
I would think so. I think tracking has been striving towards a more timeliness of our data. And as I mentioned previously, we would get data in the fall, and then that data would not go up for another 6 or so months onto the national portal. And at that point, some states could have a newer year of data available on their tracking site. So we would like to stay as timely as possible and conserve our time on the back end, if that makes sense, when the data have been submitted. And additionally, a lot of this work has been building on towards a routine analysis plan. So maybe it's less now of like zeroing in on the issue, is more of expanding onto like, what can we learn next about our data?
Great. Thank you so much. Okay, Mackenzie, if you could stop your share, we're going to move on to the next presentation. And again, we are tracking all of the Q&As that are coming in, and we will get back to that if we have time at the end of the session, but we want to get through the next presentation. So it is my great pleasure to introduce Erica Plant and Ashley Wilder. In full disclosure, Erica and Ashley work alongside our team in the Institute for Health Policy and Practice, so I'm particularly familiar with this work. Erica and Ashley are going to talk about some work that's been done with the somewhat underused dental claims that come in on many states' APCDs. So we're going to talk about that in New Hampshire. Erica is a data analyst and Ashley is a project director within the Institute. So I will hand it over to Erica and Ashley.
Thanks, Joe.
Thanks, Joe. So Ashley, did you want me to start off with talking about the data? Okay. So we are part of, we receive data from the New Hampshire APCD, which is the New Hampshire Comprehensive Care Healthcare Information System, and from Medicare. We receive extracts from these two groups on a quarterly basis, generally. For dental claims in the commercial data set, these are the approximately 550,000 commercially covered lives that are covered by Cigna, Delta Dental Plan of New Hampshire, Harvard Pilgrim, Metropolitan Life, and Guardian Life. And for Medicaid, we receive the fee-for-service dental claims data. The dates here that I am mentioning are actually the dates that we use specifically for the project in our use case that we will be talking about later in the presentation. However, we do receive many years, I believe from 2013 until 2019 for commercial, and Medicaid, I believe we have a little bit of 2013, but we actually go through 2020 for Medicaid. So we receive this data and we run it through a programmatic process of extract, transform, load, in which we are validating the files, validating certain variables, and also creating a few variables of our own based on the information in there. And we are quarantining anything that doesn't fit immediately into the criteria of what we consider to be usable for analysis. In general, for commercial data claims, and this is true for all medical and pharmacy, we generally use the plans that have over 10,000 members and fit the clean criteria after we do the QA process. Unfortunately, because of the Gobet versus Liberty Mutual ruling in 2016, we do not get the self-funded insurance plans. So these in general are the non-self-funded plans, and then Medicaid is the fee-for-service. Did you want next slide, Ashley? So when we're getting the dental data, we have to have some considerations that we think about when we're even looking at it and then using it for any projects. First of all, it's actually fairly stable in terms of the records and the membership, but is not completely immune to quality issues. Medical claims we find to be a little bit more problematic as we receive them, but dental still has some issues. So first we have to understand the dental delivery service structure. Not all plans are consistent. Some offer services that others don't. So we have to be aware of that as we're comparing things like costs, especially costs, as in if one plan covers orthodontia and restorative services, then they will have higher costs in that type of service category. And that may initially flag someone looking at the data quality as, oh, there's a problem here, but it actually is more that the plan covers. We also look at the provider versus population. So in certain different demographic groups for children specific to dental, again, orthodontia comes up. It tends to be a service that is used in a certain age bracket. So we are, have to be aware of that as we're going through the process. As also, we need to think about Medicaid versus commercial. Medicaid does not cover as many services as the commercial plans do. So we generally do not compare the two payer types to one another. We compare the payer types to itself over the years, over months, and between extracts. And then the other consideration that we need to think about is if we're using the dental claims data for analysis that requires us to link it to medical claims through the member, then we also have to be aware that not everyone has dental insurance, or a member may be eliminated or not eliminated, quarantined due to a quality issue in one data set versus the other. So this could affect our sample size greatly. So there's something to consider, as well as if we're doing an analysis that actually tries to correspond dental services to medical services, vice versa. We use the dental claims will use the CDT codes versus the medical claims using the CPT codes, and there isn't a really clean crosswalk for that. Some crosswalks do exist, but it's really best if we get some clinical advice when we are doing those projects. So those are things we have to think about as we're working through the dental data. Next slide. So as part of the process, we receive the data from, like I said, New Hampshire CHIS and Medicaid, which have their own QA processes before we even receive it. But once we do receive it, we do our file checks, format, variable field checks, run it through the process of the ETL. And then we have a number of reports that our process actually spits out. They are split out into categories of claims versus and eligibility information. And in the eligibility information, we look at information about persistency. So the number or percent of members gained, lost, and retained over months over a certain year. We have a report on continuity, the number and percent of members with contiguous coverage over the year and over the months. And we also have reports on demographics and geographics. So we can also look at costs and eligibility for age as well as region, just to give us an idea of if we're seeing anything that is unexpected, inconsistent, somewhat like trend lines of sorts. Then we can also look at costs. So we look at PMPMs per month, PMPMs on average over the year per payer. Are they reasonable? Are they too high? Are they too low? Oftentimes they're lower than we expect, and that indicates an issue. Possibly an eligibility set has not been sent over. We do have to be aware, though, that dental PMPMs can range as low as $17 per member per month to $91 per member per month, given a plan structure. So as we become more aware and understanding how these different plans work, then we have a certain criteria that we look for. And then we also have a unique process. So many groups that work with claims will quarantine or drop any claims that do not have members with a corresponding enrollment file. However, we do that, but we also have a program that produces a ratio to look between enrollment and claims. So if a group, so it's group under a payer, so say Anthem's certain plan, if they have over 50 members, because we don't want to work with a group that's too small, and they have a ratio that is too low between the number of members in the plan and the number of claims that have been submitted, they are flagged and quarantined. We do have a specific ratio that we use for dental, which is less than 5%. We are looking for next steps to possibly modify this based on maybe age groups and certain demographics. So that would be a next step for us in this QA process. We also do run this for medical and pharmacy. This way that we don't have these plans are not affecting the overall PMPM and integrity of the data. And then we also review the type of service to look for anything that may give an indication of a coding situation. For example, in the past, there was a particular plan that was submitting a code with a 0 as the first number or digit or whatever instead of a D. And it was actually coming out in our type of service program as anesthesia. And it seemed like there was a large amount of medical anesthesia codes in this dental claims. It actually turned out it was one of the plans was just submitting the wrong information. It was supposed to be a D instead of a 0. But that report specifically pointed that out to us. We might not have seen it in the analysis because the actual costs were fairly low, but it could have skewed some of the utilization information that we were working on. And then once we actually go through the entire process, we finalize what we are going to select as what we call our research ready data set, which is what you saw at the beginning of the presentation. And that accounts for approximately 86% of the extract itself. And if we have any recommendations, we submit them to the New Hampshire Healthcare Information System Group or Medicaid itself. That way that they can move forward and make some adjustments or speak to the actual plan groups, insurers, to correct some of those issues. Did you want to go to the next slide, please, Ashley?
Real quick, just to let everybody know, we have 10 minutes left in the session, and we do have a hard stop at 10 minutes past the hour.
Thank you.
Thanks, Norm. So I'm going to grab the baton from Erica because I'm up. Good afternoon to many of you and good morning to some of you. I'm Ashley Wilder. Joe, thank you for that introduction. I am so happy to virtually see many of you. This work that I'm about to pop through is what I do for the Institute for Health Policy and Practice, wearing one hat. Many of you know me through my work with the APCD Council Learning Network. So it's just a pleasure to be here virtually. And thank you, Erica, for that overview of our dental claims data QA process. I'm just going to speak quickly here about what we're doing with our dental claims data. And so we were lucky enough in 2017 to receive some funding through the New Hampshire Children's Health Foundation to begin using dental claims data. What began as some in-house analysis of commercial and Medicaid fee-for-service claims turned into an online reporting tool. In the world of transparency, we were excited to be able to fund a project where we could put an online reporting tool out there just to demonstrate how New Hampshire dental costs look, as well as visit rates. And I'll show you 3 screenshots here in just a second. Of our oral health report suite. We didn't want to do a live demo with all of you today, but we do have a link that we're including in this presentation. So you can spend some time going to that site and checking that out. And so what started in 2017 as reports turned into a prototype of an online reporting tool, which we vetted with our funder as well as the oral health stakeholder group here in New Hampshire, which has representatives from payers, and some nonprofits here in the state. We released our first version of that oral health report suite last year, and this year have been given some additional funding to add some new years of data to the report suite, as well as some new analysis that is specific to preventative services, surgical, dental services, specifically in the ED setting. maybe. Here we go, sorry. So the next 3 slides are just screenshots of our 3 report types that are in our oral health report suite. This one here is an overview of dental costs reflected as PMPM, as Erica mentioned before. Our little tiny URL here is how you'll get to the report suite in a separate time. But we're just really excited to be able to provide this type of analytics for all of you to see. The yellow bars here, it's a little bit small, sorry about that, provide a dental PMPM for a previous analytic period, and the blue is the current analytic period. We are able to pick specific geographic regions to look at dental costs, as well as by payer and age and gender groups. In New Hampshire specifically, our geography is not isolated, but our geography is defined as our integrated delivery networks. So this is our overview of total dental PMPM. This next screen shows dental PMPM and our visit rates. And this is in the Medicaid population specifically. So we do offer analytic reports from our commercial payers as well as Medicaid fee-for-service. So this is just another view for you to see. And we have a comparison report. So we're able to give anyone who goes to our site the ability to compare specific geographies as well as age, gender, et cetera, side by side, so that you can see PMPM over time. Oh, did I cut out? No, okay, great. So I know I got through that quickly, but I got the time note from Norm. And so that is the Oral Health Report Suite.
Thank you, Ashley. Okay. We're going to take a few questions. Let's take a couple directly for Ashley and Erica. The first one came in from Jim, who asked about whether or not there is a benefit plan indicator in the data, including for such things as is it a plan with orthodontic benefit or not?
I don't believe that we do receive a benefit plan indicator. We do have group indicators and maybe some indicators about the plan in terms of different different levels. But in terms of types of service, we actually have a program that's the transform part of the ETL process, where we take the information from the claims and are able to build what we call a type of service, and that gives us that information in almost a node form. So it'll be part of the 4th node. It will be professional, and then dental, and then orthodontia. So in that case, it'd be 3 nodes. But that's how we get that information, is from the claim line, but not necessarily whether or not the overall plan in the enrollment information. I don't believe we have that.
No. And then another one on this, and then we'll switch over to a couple questions from our other presenters as well in the 5 minutes that we have left. How complete is the dental provider data, and are you able to determine provider affiliation amongst dental groups?
We can, I believe it's fairly complete. Given, in terms of filling out the actual claims, I find it to be fairly complete. We do quarantine things that don't have a certain level of completeness. Provider affiliation among dental groups, I'm assuming the question is, is the MPI provided? I think that's what they're asking. I believe it is in that claims information.
But we would have to get some sort of more manual process to put providers together if they're claiming as individual providers.
Yeah, exactly. Yeah, for dental groups, yeah, that would be tough. And that's not part of our QA process. That's one thing we don't. We do look at specialty in some things, but not particularly individual provider groups.
Thanks. So I think the sign of every good session is more questions than can be answered in the time we are given, and we are absolutely in that scenario right now. So I want to go back to some early questions just to close us out. So we're going to go back to Catherine here for a minute, and there was a question early on, Catherine, for you about whether or not race was considered in the readmission analysis that you all did.
Yeah, that's a great question. So we do get race information on our hospital inpatient discharge records, but we have not yet publicly reported on some of the differing readmission rates by race. But that is definitely something that we have the information and data to look into and potentially report in the future.
Great, thank you. And a question for Mackenzie from Sterling Peterson. Have you considered how the quality checks may have to be adjusted in the pandemic era?
So we are currently coming up to our fall 2019 data call. So I think right now we won't see the pandemic reflected in our data, because I think the most recent data we'll be getting this fall will be through 2018 with a few states with 2019 data. So that will be something that we have to consider in the future. We have had similar situations, like for example, when we transitioned from the ICD-9 coding to the ICD-10 CM coding, we went into that data call with expectations that we would be seeing variation in the data. We do still, with our protocol, follow up with states if we observe like spikes or large declines, just to make sure that those changes really are because of the pandemic or coding changes or any of the above. So we will probably continue to follow up when we first see the change happen.
Great, thank you, Mackenzie. All right, last question, because I know Norm will just shut us off after that, which is around data validation in the dental data. So Erica and Ashley, two questions that came up about tooth number, tooth surface data, which we can talk a lot about, how that affects the claims and some validation around that. And there was also a question about validation rules for the CDT data. So just wanted to ask about the validation rules and processes for those fields, tooth number and the CDT codes.
And I will have to admit that I don't know the current status on tooth number, Joe, so I have to apologize that, but I know it's something that they're trying to get. And I do wish we had it, because it would help us a lot for analysis, not necessarily in this claim suite, but other analysis that we have done. I do think it affects how the claims are now analyzed. So I don't know what the latest is on that, but I know that there was information on the tooth, but I don't know that we have the actual number as of yet. So it's something to look into. As far as the CDT codes, we do validate a little bit, yes. As part of the process, we expect them to be within the ranges. As I mentioned before, where there was a code without a D in front of it, and that was quite odd. So we validate in that sense. We also do set aside some codes that don't fall into the expected, CPT, or if it's a CPT, we may keep it in our report, and then the report will tell us, oh, there's something outside of a CDT in your dental claims, which we can look back at. But if it's not even
time.
Oh, thank you, Norm.
All right. Thank you, everybody. Thank you to Catherine, Mackenzie, Erica, and Ashley for presenting and for the great questions. Email addresses are in the conference speakers. So any question you had in the chat that didn't get answered, you can email directly to our speakers. Thank you very much, everybody. And on to the next session.
Thank you.
Thank you.
Please join us on the NASHP platform for our joint plenary. If you have any trouble with that, just look in the lobby. There'll be a link there. Thank you. Bye-bye, everyone.
Thanks,
Bye.
Norm.
Thank you.